Good afternoon, everyone. My name is Monica Valdez-Lupi, and I'm the Chief of the Health Systems Transformation Team here at the Association of State and Territorial Health Officials, ASTHO. I'd like to welcome everyone to today's webinar, which is entitled The Role of Public Health in Healthcare Reform, Lessons Learned from Massachusetts. And it's my pleasure to introduce our speaker for this afternoon's webinar, John Auerbach. John is a distinguished professor of practice in health sciences and the director of the Institute on Urban Health Research and Practice at Northeastern University, where he's led that work starting in 2012. Before joining Northeastern, John served between 2007 and 2012 as the Commissioner of Public Health at the Massachusetts Department of Public Health, where he oversaw over 100 different and distinct programmatic units, including those addressing chronic and infectious disease, substance abuse, environmental health, and public health preparedness. He was a member of the team at the Executive Office of Health and Human Services that played an instrumental role in implementing the state's groundbreaking healthcare reform law. It's a pleasure for us to have John join us this afternoon on this webinar. Before I turn it over to John, however, I wanted to let the participants know that if you have a question during the webinar, you're welcome to post it in the chat box, which you'll see at the lower left-hand corner of your screen, anytime during John's presentation. These questions will be answered during the Q&A at the end, and we'll also open up the phone lines during the Q&A session for participants to actually ask questions directly to John. At the conclusion of the webinar, you'll be directed to an evaluation survey. Please take some time to help us by completing this survey because we really appreciate your feedback and use your comments and guidance to help us in programming future ASTHO webinars. So with that, I'm going to turn it over now to John.
Thank you, Monica, and thank you also to ASTHO and to CDC for sponsoring this webinar. And good afternoon, everyone. I'm delighted to have the opportunity to speak with you all about some of the public health-related lessons that we learned from our healthcare reform initiative in Massachusetts. Of course, every state is different, every state and local, and they're different in terms of the number and percent of those who are uninsured. They're different in terms of the availability of primary care sites and clinicians. There are differences about the receptivity to the Affordable Care Act, often most dramatically illustrated by the expansion or non-expansion of Medicaid. All of those factors affect your environment. And but I hope that in spite of the differences in people's environments and the context in which you work, this is still valuable for you. I should note that often as I will be talking during the webinar, and I refer to healthcare reform, I'll be referring to it writ large and not simply with regard to the Affordable Care Act. I've certainly heard from many states where there isn't support among elected officials for the ACA that there's still talk of the need for some form of healthcare reform with accessible insurance coverage or payment reform to control costs and improve quality. And therefore, some of the lessons from Massachusetts might resonate with you, while other ones might seem to be of no value at all given your context. But even with that caveat, I do hope that there's something of interest or use to most of the people on the call. Okay, let's just see, I'm moving this ahead. Let me start by reviewing what happened after we passed an Affordable Care Act-like bill in Massachusetts in 2006 and then began to implement it in 2007. I became State Health Commissioner in 2007, just as it was being implemented, and I was fortunate enough to participate in the Health and Human Services team that was overseeing a good deal of its rollout. To be frank, though, in 2007, we really didn't know what to expect. The most important change that occurred with the bill's implementation was a very rapid increase in the percentage of the population who had health care insurance. We saw the percentage who were uninsured decrease from between 6 and 7% to about 2 to 3% within the first year alone. And that was a reduction of about 2/3 of those who had previously been uninsured within the state. The percentage of those people who are uninsured has hovered at about the 2 or 3% level in Massachusetts over the 7 years since then. And it's not expected that it's going to be decreasing below that current level. This is a point where it's worth emphasizing that one of the most striking differences between Massachusetts and much of the rest of the country, even before health care reform, was that our percentage of uninsured in Massachusetts was less than 50% of the rate it was in the rest of the country. And it was about 25% of what it was in those states with the highest percentages of uninsured. Nonetheless, the accomplishments of dropping the number of uninsured precipitously was impressive. Not only did our residents gain health insurance coverage, we also saw evidence that the coverage resulted in increased access to care. About 91% of the population reports that they have had a primary care doctor, and about 80% of the population report in recent surveys that they've seen their doctor and their dentist in the last year. An additional point worth making on this slide is that healthcare reform wasn't as controversial in Massachusetts as it was in other parts of the country. About 2/3 of the population in our state gave it their approval almost from the beginning, and that percentage has remained relatively steady year after year. Just this week alone, a new survey came out that indicated that the percentage of support was largely unchanged, even though there was a poorly functioning insurance exchange in Massachusetts in recent months. This chart demonstrates that there was a strong connection between insurance coverage and access to health care. And that may seem self-evident, but it's still worth pointing out that we noted that when we looked at those 97, 98% of the population who had health insurance, about 86% of them said that they'd seen their doctor in the last 12 months. On the other hand, when we talked to the 2 or 3% of the population who still lacked insurance, they were much less likely to have seen a doctor in the last 12 months. And as you can see, the percentages for them was closer to 50%. And then, of course, for people in public health, there's a great deal of interest in those who receive preventive health care services. This chart shows that about 3/4 of the people who had insurance in Massachusetts received what might be called a preventive health care service, such as an immunization, vaccine, or a screening for a particular disease. On the other hand, those without health insurance were only about 1 in 3 were likely to have received a preventive health care visit in the last 12 months. So the lesson clearly is here that having health care insurance does increase the likelihood that you'll be able to see a doctor. We also examined if there was evidence that such access to care resulted in short-term and measurable improvements in health. In most instances, we used surrogate markers to assess this, meaning that we didn't have the actual health outcomes in the time period we were looking in, but instead we studied the changes in utilization of certain services that were known to be directly related to improved health. This chart gives you an example of what those were. This is information that we gathered from a survey of people with diabetes. and we asked them whether or not they received the 4 recommended preventive services for people with diabetes, and those include A1C test, eye exam, foot exam, flu shot. Before healthcare reform, about 12% of the diabetics in the state said that they received all 4 of those recommended preventive care services. Within 2 years of healthcare reform, that percentage had grown to 20%. So we saw a significant increase, but of course, as you will note, 20% is certainly way lower than we'd like to be. We also looked at the health of people with asthma, and what we were able to see from the surveys that we did is that people with asthma were much more likely to have health insurance after healthcare reform. It was a statistically significant increase in just a short amount of time, and less likely to have money as an obstacle to seeking care, more likely to receive a flu vaccine. And that's important given their greater vulnerability to illness. This chart shows that we also saw increases in some of the screenings for cancers and other illnesses. And I draw your attention in particular to the dramatic increase in the percentage of age-appropriate residents who received either a colonoscopy or a sigmoidoscopy. We saw a statistically significant jump in just 1 year, where we went from 55% to 63% of those individuals who were age-appropriate who had received the test. And then we saw a very interesting phenomenon with our the enrollees in the Medicaid program. We had an increase in terms of the percentage of people who were able to be eligible for Medicaid, and at the same time in Massachusetts in healthcare reform, the legislature required that Medicaid for the first time would offer a smoking cessation benefit. We didn't know if that would have an impact, and we're delighted to see that within just a couple of years, there was a very sharp decrease in the percentage of the Medicaid enrollees who smoked. And you can see that's the purple line that drops off precipitously after healthcare reform was implemented, whereas the green line, which is the percentage of those who remain uninsured, decreased very slightly in terms of the percentage who smoked. One of the important lessons that we learned is that some of the most noteworthy improvements in health occurred when public health campaigns were tied to increases in access to health care insurance. For example, when in the first 15 months after the Medicaid expansion and the addition of that smoking cessation benefit that I mentioned, the Department of Public Health rolled out a physician awareness and public awareness and support initiative. The Department of Public Health ran advertising informing the public that they could now get smoking cessation services if they were on Medicaid. And in parallel, the health department notified physicians of the benefit and provided them with educational materials and also helped them connect their patients to the state-funded quit line. And what did we see as a result? We saw this. Now that bar at the bottom, the red bar, indicates the period of time when the public health department was running those educational efforts and also providing information to physicians. During the 15 months that the Department of Public Health led that campaign, the utilization of the cessation benefit among Medicaid recipients rose pretty steadily. And when the campaign ended, and that's where the red line ends on the chart, then both the awareness and the utilization of that benefit began to drop. We also wanted to look at whether the decrease in smoking among Medicaid enrollees resulted in any kind of a short-term or measurable improvement in health. To do that, we were involved in a study together with our colleagues in Medicaid that examined the utilization of more than 20,000 Medicaid enrollees, and we looked at patterns of utilization of care and information about diagnoses both before and after healthcare reform. And what did we find? Well, we found an astounding 46% decrease in hospitalizations for heart attacks and 49% decrease in hospitalization for acute coronary heart disease for those Medicaid recipients who had taken advantage of the smoking cessation benefit. We were also able to calculate short-term health care cost savings as well as these improvements in health care outcomes, and we did so within just an 18-month period after health care reform was implemented. We saw the benefit of linking public health efforts with healthcare reform in another campaign as well. This one targeted newly returned veterans who had some of the highest rates of smoking of any groups in the state. Most of these veterans had insurance that actually covered smoking cessation benefits like like medication to help them stop, but they weren't using those benefits. So public health officials designed a specialized campaign that was just for veterans, using imagery and language that targeted them specifically, and the information about the availability of a free patch program was distributed only through local veterans assistance offices. We weren't sure whether that would make a difference since, as I said, most of these veterans already had access to this kind of coverage through their own insurance. And we offered 1 month of free patch and counseling for veterans and their family members during the 7.5-month campaign. And we expected in our budgeting and planning that we would be serving 1,500 veterans. Instead, 4,000 veterans called the quit line as a result of this campaign, and more would have called, but we ran out of money. The veterans relayed that they liked the specialized effort that the public health experts had developed, and that appealed to them and their families and motivated them to take action. We also found out that we had a high no-smoking rate among this group even months later, after they had begun use of the patch. And with most of these veterans, we were able to transition them over so that they would use their insurance for the second month to purchase a patch. But this was an indication that public health was very helpful in terms of linking up to the available services and maximizing the likelihood that they would be taken advantage of for health-promoting activities. A final example of the value of linking public health efforts to healthcare reform is offered by the Massachusetts experience with reducing the spread of HIV. Public health campaigns reinforced the importance of HIV testing and helped link the public, particularly folks who might be at risk, to testing sites. And then the public health department also paid for prevention messaging. Many HIV-positive people gained access to healthcare services with the help of the expanded insurance coverage, and we believe that the combination of the public health information about the importance of testing and the availability of high-quality services may have contributed to the steady reduction of new HIV infections year after year in Massachusetts. And this is in contrast to the rest of the country where new infections are still relatively stable in most places. There's evidence that the combination of the high rates of testing and ready access to excellent care resulted in a reduction in viral load among many of the clients, and that made them possibly less infectious. So the conclusion from these examples were that far from making public health obsolete, healthcare reform actually works well with public health to reinforce the importance of taking certain actions when seeking clinical care, and can work productively with clinical partners. One caveat is that the continuing value of public health wasn't always recognized in Massachusetts as we rolled out our healthcare reform initiative. At times, there were assumptions by the legislature that certain public health services were no longer needed due to public health, due to healthcare reform, that is. This resulted in cuts to such programs as the tobacco prevention program, to immunization programs, and reproductive health programs. And to begin with, we weren't sure whether those programs would still be needed as a result of healthcare reform. What we found is, in a number of instances, they were still necessary, both for the populations who remained uninsured or for populations who, for one reason or another, weren't using their insurance for certain kinds of services. At times, public health officials, providers, and our advocates were able to make the case with the legislature that some of these assumptions were flawed, and in some instances, public health programs were refunded. And this highlights the importance of being prepared to defend the value of public health programs as early as possible, with as much information as you can gather about whether or not expanding access to health insurance will have a direct impact on the provision of those services. At this juncture, I'm going to shift gears a bit and talk about the 5 lessons I learned regarding public health's involvement in healthcare reform. And for those of you who are interested in finding more out about these lessons, I refer you to an article I wrote in 2013 in the Journal of Public Health Management and Practice that focused on the 5 lessons. Okay, so lesson number 1, get a seat at the table. In order to have an impact on the deliberations of healthcare reform in your state, there's just no way of getting around the fact that you have to be following what's happening, you have to determine where decisions are being made, and you have to make the case that you have something to contribute. In the first few months of the healthcare reform initiative in Massachusetts, there were numerous planning meetings that were taking place, and for the most part, people from public health weren't invited, and often when we were, we did feel like we were the children at the table and dining with the adults. We learned the hard way that if we didn't fight for a seat at the table and struggle to demonstrate that we had value, others who were there would make decisions that affected public health. And so from this experience, a few things became clear to us. One was we needed to understand the basics about insurance, and that included the technical language and the detailed concepts of insurers that often public health folks don't know. And since no one was going to teach us, we had to determine how best to educate ourselves. A second lesson that we learned is that we needed to respect and appreciate the values, priorities, and incentives of the insurers. And that meant getting over what was a commonplace attitude of myself and others in public health, that insurers were just motivated only by the bottom line and were uninterested in the promotion of good health. And we needed to understand that there were many different values that we shared and that we could work collegially. Third, we had to face up to the fact that a number of our core assumptions in public health just didn't have sufficient data to substantiate them. We were accustomed very often to talking about prevention, it being self-evident that prevention saves money. And we often just didn't have the data to demonstrate that. And so we concluded that we needed to take additional steps to try to have hard information that showed us you could actually get a return on investment in a relatively short amount of time with public health interventions. And when I mentioned earlier the analysis of the reduction of smoking and how that led to fewer heart attacks, and then we could quantify the costs saved from fewer heart attacks, that gave us better credibility among the insurers. Okay, then there's the second point. That's to take an open-minded and critical look at the work public health does now. Our initial impulse in public health during healthcare reform was just to assume that all of the existing public health service would still be necessary, and we were worried about cutbacks, so we kind of had what might be called a circle the wagons kind of approach. But the downside to this approach was it discouraged our taking a more balanced and analytical assessment of the likely impact of expanded healthcare coverage on individual programs. And we didn't always see results that we would have expected. For example, we did see a dramatic decrease within months in the number of women who were enrolled in the Women's Health Network program that provided breast and cervical cancer screening. Many of them, when they would come in for their screening, would be enrolled in an insurance program and they're no longer be eligible for Women's Health Network. On the other hand, we expected to see the same kind of drop in our AIDS drug assistance program, and we didn't see that. And we had to keep going back and examining why it was we weren't seeing a decrease in one area, but we were seeing it in another. We concluded that what we needed was a systematic approach to review our program models throughout the department and to analyze client and patient populations that were being served, looking at barriers to access to care both pre and post-reform, and also the feasibility of altering the funding sources by billing insurance or by privatizing a service. We needed to take seriously the feasibility of transitioning some of our historically provided services away from public health and into primary care medical homes, and or to start billing for historically free services. And so for each of the services that you see here, we made significant efforts to try to either transition those services into primary care medical homes, FQHCs, and community health centers where we could. We couldn't always do that. And if we couldn't do it, to take steps to try to maximize our ability to collect insurance reimbursement wherever possible so that we diversified our funding base. The third lesson is defending the traditional public health approach when it's called for. In Massachusetts, one example where we had to do that involved the potential loss of childhood immunizations. In the first year of healthcare reform, the state legislature eliminated all the state funding for mandated pediatric vaccines, and that was a cut of $52 million in our budget. And we understood that they thought, well, now people have insurance, why should we be paying for those with a line item in our budget? But it turned out it was much more complicated than that, and the State Academy of Pediatrics and many of its members raised to us very significant concerns about the complications involved in their assuming responsibility for billing for vaccines that they'd never had before. And we went through a good deal of planning, and to avoid any kind of setback in our childhood immunization rates, we formed a broad coalition. It met for months. It ultimately worked with the legislature and decided that the best approach was to assess the insurers for the cost of the immunizations and put that money back into a fund within the Department of Public Health so that the mechanism of distributing free vaccines to pediatricians could still take place. The insurers themselves ultimately saw the value of this approach and gave their support, and a crisis had been avoided, but it was only after spending a lot of time and resources negotiating and organizing. Thankfully, there's been a number of very useful efforts and materials to help states determine what is essential and what isn't. ASTHO has very useful tools from its strategic planning. They're available on the ASTHO website. But it's helpful for each state and for locals as well to consider their own needs for such planning and analysis. And in addition, there are a few new insightful documents that are very helpful for people to draw upon, and I'll just mention a few of these. They include there's a new document that on the Robert Wood Johnson blog site that's the High Achieving Governmental Health Departments of 2020 as the Community Chief Health Strategist. In addition, the Public Health Leadership Forum has published an article that defines about what is defining and constituting foundational capabilities and areas. And finally, CDC has a document that's the core functions of public health and how they relate to the essential services. Those documents are very useful when you're trying to make an assessment about what's actually core activities in public health and what activities might be transitioned over to primary care sites as insurance expands. And for those services that are core and essentially part of the effort to keep them involves working with ASTHO to provide information to our elected officials as well as working at the state level. NACCHO also does a wonderful job of ensuring that elected officials are well educated. And so those efforts are important in terms of, in particular, reinforcing public health core activities. The fourth lesson is to be on the lookout for new opportunities. And here, through trial and error, we identified a few new and important opportunities. Oops, I think I went a little too far. Let's see. Great. One important area that we looked for were places where public health could help reduce the cost of health care. And that may seem like a difficult challenge, but in Massachusetts, as well as in the rest of the country, there are lapses in quality of care that can result in additional preventable costs. And two areas in particular that add significant costs for health care are healthcare-associated infections and incidents that are sometimes referred to as serious reportable events. They're like injuries from falls in hospitals or nursing homes. And we learned that we could play an important role in convening hospitals and nursing homes to identify best practices and to provide educational and technical assistance about ways to improve quality, better for the patients, but also important in terms of thinking about reducing costs. We also learned that we needed to pay attention to the determination of need and certificate of need processes and think about their role in both quality and cost. And such efforts gave us greater credibility among the insurers and the officials that were overseeing healthcare reform. A second area I'd mention is that public health has an important role in documenting the improvements in healthcare reform. Much of the justification for healthcare reform relates to its promise of improved health and health outcomes, but there actually is surprisingly little attention to looking at this. And we decided that an important role for public health was to document as many outcomes as possible. And you saw some examples of that at the beginning of this PowerPoint. Payment reform often accompanies healthcare reform, and payment reform also offers potential, particularly with the move away from fee-for-service towards global payments, and within that, the chance to cover more population health efforts. And so it's important for public health, local and state agencies to be involved in the discussions around payment reform. A second example of that is the importance of participating in the discussions that are taking place in many states about health metrics and helping to identify those that we think should be promoted and given financial incentives to providers. And here I would just mention that with support from the Robert Wood Johnson Foundation, my institute at Northeastern is soon undertaking a new initiative, a national initiative, to develop these population health metrics in a format that may be useful for you as well as for insurers and providers. The fifth and final lesson is to envision a better model and take steps to make it real. And in this regard, CDC Director Tom Frieden has provided a very useful visualization of what this new model could look like, namely working increasingly on changing the context, the next to the last level of the pyramid, and trying to reach as many people as possible through thinking about altering the conditions of their lives and taking steps to have an impact on policy. There are two examples of this I would highlight from Massachusetts. One was the successful creation of a $60 million Prevention and Wellness Trust Fund. That trust fund is now distributing, or has now distributed, money to different coalitions in the state that are working to link clinical care with improvements in community conditions. A second example in Massachusetts was the formation in the state of a community health worker certification board that was intended to make it more likely that community health workers were incorporated into the provision of primary care by establishing standards for quality and actually giving some assurance to providers that training meets high-quality standards. There are also many examples of this nationally. There's Robert Wood Johnson Foundation's new Culture of Health approach. There's the federal government's National Prevention Strategy, released and authored by the Surgeon General. And the Centers of Disease Control has established a Social Determinants of Health Workgroup, which is working with states across the country to think about how to emphasize more the attention that's needed to the social determinants of health. And there's some indication that this approach is already working, and I assume that many of you have seen the reports that show that in the last year or two, for the first time in decades, we're beginning to see the leveling off and in some cases the slight decreases in the rates of growth for children who are obese and overweight. And many people believe that that is a result of this broader approach that looks at not simply providing a direct service, but changing the conditions in people's lives so that the communities, workplaces, and schools make the easier behavior, the healthier behavior. This is a sentinel moment in our history, and people in public health at the state and local level can make a significant impact. Now, I would say that there are days when it feels like all of public health is at the bottom of a very steep learning curve when it comes to understanding the ways that we can contribute to improving health in an era of healthcare reform. And even after 7 years of healthcare reform in Massachusetts, many of us still feel that way in Massachusetts. We're still learning. But like it or not, the world around us is changing, and it's changing fast. And public health officials have valuable contributions to make to the health promotion and disease prevention of our residents, as well as to the future of the public health enterprise. If there's one underlying observation we learned from our experience in Massachusetts, it was that we had to try to get ahead of the changes that were taking place. Instead of just reacting to them, we're standing on the sidelines and watching as healthcare reform was being implemented, primary care medical homes were being established, and healthcare was evolving. My main message would be to take as many steps as you can in your environment, in your department, to become fully engaged in healthcare and payment reform, to be as well informed as possible, to inform your departmental members, to think analytically about the current and coming changes, and to be open to new and different ways of doing things while at the same time steadfast in defending the core efforts that must be preserved. And so in closing, I want to say again thank you to ASTHO, to its executive director, Paul Jarris, and to Monica Valdez-Lupi, and to CDC. And we're very fortunate that ASTHO exists and provides us with information, tools, and opportunities to learn from each other as we continue to adapt to healthcare and payment reform throughout the country. Thank you.
Thank you so much, John, for setting us up for what I'm hoping and anticipating will be a really rich discussion following your slide deck. If it's okay, I'm just going to go ahead and start with a couple of questions that we received in the chat box while you were presenting, John. And the first question comes from David Carvalho, and the question is as follows. Are you sure the drop in the percentage of Medicaid enrollees smoking is due to the cessation benefit as opposed to the dramatic change in the categories of who is in Medicaid? And that's the first question from David.
The researchers that looked at this controlled for a variety of different demographic, income, and other characteristics because they wanted to be sure that this wasn't a result of a new and different type of population on Medicaid's rolls. So I think that that was accounted for in the research that was done.
Okay. The next question, John, is from Claudia Brown. And she asks, is there any data on asthma preventive measures as a result of the ACA on children and youth under 18 years?
There is interesting data that has looked at non-traditional ways to prevent hospitalizations and emergency room visits for children that have moderate to severe asthma. There's been a well-evaluated study that showed that asthma prevention programs that involved home visits from health educators with efforts to reduce triggers in the home, paying for things like mattress covers, and the elimination of mold and mildew in the windows or other parts of the apartment, were both cost-effective and health-promoting. And the evidence of that was strong enough for the Medicaid program to request a waiver to allow a pilot of reimbursing for those kinds of services, which really are the kind of services that are what are being thought of for a variety of different kinds of health issues in the primary care medical home model. So with regard to particular types of interventions that that have an impact on preventing childhood asthma, I think that's been the arena where there's been the most evidence.
Okay. Thanks, John. Operator, can you help us open up the line for some questions?
Certainly. Ladies and gentlemen, if you would like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. One moment, please, for the first question. It looks like there are no questions on the phone lines at this time.
Sean, if it's okay, as people are thinking about potential questions, is it okay if I ask you a couple of questions? You began talking about third-party billing, and I know that that's a topic that both the state and local health departments have been examining in terms of how to maximize billing and the collection of those third-party funds from insurers. And just curious if you had some observations based on the work that you're doing around STD billing about how health departments can keep or retain those revenues that they're bringing in. I know in Massachusetts there was a whole separate process or challenge in terms of retaining those additional revenues, and just wondering what you've heard in some of your subsequent work.
Sure. Thanks for that question. The ASTHO, with support from CDC and also in conjunction with NACCHO and the National Association of Community Health Centers and the National Coalition of STD Directors, has been involved in an effort to understand whether STD services can be integrated into primary care. And one of the issues that has come up repeatedly is the one that you mentioned, Monica, and that is when health departments are retaining STD services and more people have insurance, is there a way for them to collect insurance and to keep it? What we found was there were a number of different issues that are raised in terms of moving away from the traditional model. The first one is having a mechanism, an administrative mechanism to actually gather information about it from the insurance cards and bill the insurers. And there what we heard from a number of locals and states was that if they didn't have the ability within their own department to do that billing in an accurate way, they were often able to find an administrative service within their community that would provide that function, keeping a portion of the revenue themselves in exchange for providing that service. A second obstacle that people identified was that the culture of clinics themselves is welcoming and hasn't historically involved the collection of insurance, and there was concern that this could create an unwelcoming atmosphere in an STD clinic. Some of the health departments talked about the importance of working very thoroughly and cautiously with their staff to develop scripts that staff could use to make it clear that they were interested in collecting insurance, but that no one would be turned away, and having that kind of attention to saying things carefully so that the concerns around creating the wrong atmosphere in STD clinics, it was possible to overcome that with enough care and attention. And then the third area was that many programs wanted to distinguish between the patients who went to STD clinics who might now, with insurance, choose to go to a primary care medical home versus those who either didn't have insurance, still didn't have insurance even after the expansion of some opportunities, or chose not to go to primary care because they felt comfortable in STD clinics, that those patients could still continue to go to the STD clinics and still take advantage of the services, and that there needed to be a way to estimate how whether or not the services could be scaled back but still serve that population that needed it, and that took a good deal of screening and better understanding of the patient population. So all that is to say, in order to move to collect third-party reimbursement where that's not part of the culture of the health department, it really takes a lot of thought and planning. But it's possible to do it, and more health departments around the country are doing it, retaining the resources and using it to offset cutbacks.
Great, thanks, Sean. We have some, as people are queuing up to do the live questions, we have a bunch of questions coming in through the chat box. I think your slide and your comments about the work around workforce and the chief public health strategist have piqued people's curiosity. And we have a couple of workforce-related questions. One is, what skills do new or existing public health workers need to be effective liaisons with healthcare systems? And then related to that, the evolution of the public health workforce generally to be able to adapt to all these new changes in delivery reform.
Well, great. I think there's not a simple answer to what those skills are. It certainly does require, with regard to the first question about, for those people that are liaisons to the healthcare system, what skills are needed, I think the most important skills are an openness to reach out to the healthcare providers in the community, perhaps first assessing who are the key ones. Are they community health centers? Are they large practices? Are they hospital outpatient rooms? And approaching them with respect for the work that they do and a willingness to establish some new relationships. We certainly have heard from more and more health departments that have established initial meetings with some of those healthcare providers where the starting point was just saying, how can we be helpful to each other? And what are some of the things that you're encountering where public health might be useful, talking those through, understanding more about what the specific conditions are within those primary care sites, and then perhaps going back and doing some additional research and study about the issues that may arise, and those issues may be everything from some of the health insurance specifics as well as some of the confidentiality issues and the IT innovations that are evolving.
Thanks, John. Operator, do we have any questions queued up?
We do not, but as a reminder, if you'd like to register a question, please press the 1 and then the 4 on your telephone.
Okay. I'm just going to keep going since we have time, John. We have some additional questions in the chat box. You talked about the RWJF project and population measures, and we have a question that came in through the chat box asking if you could speak more about specific measures focused on prevention that healthcare and public health could collaborate on. And I'm assuming that this may be related to some of the work on population health and improving population health.
Sure. Well, maybe I'll back up just for a second to say that the framework here is that increasingly in payment reform around the country, there's a movement away from the traditional way for paying for health care, which is a unit basis, a unit of service being reimbursed in a fee-for-service approach. And that there's more and more approaches that have what is sometimes called a value-based or global payment, where providers get a fixed amount of money for providing a range of services, but they have much greater flexibility in terms of what they do with those funds, as long as they're able to demonstrate they're providing high-quality care and the patients are healthy. If the goal there is to encourage clinicians to take steps to make their patients healthier, it offers an opportunity for public health officials to make the case to their providers that there are some public health strategies that may be very effective in improving the health of the patients in a particular practice. Of course, there we really have to know the evidence base for that so that we can speak concretely. The thinking behind the project that I was mentioning earlier is that there is value in being able to present to the insurers in your state a list of population health metrics that have a strong evidence base, and with the argument that insurers should consider providing a financial incentive for clinical practices to invest in those population health approaches because it may be in their financial interest as well as in the interest of the patients. So what's an example of that kind of thing? Well, sometimes it's thinking outside the box in terms of how to work with patients, and it could include community health workers going into the home in the way that I was describing that, the innovative asthma model. But it could also be creating a financial incentive for clinical practices that perhaps have a high percentage of patients with diabetes where the patients are just having a difficult time changing the way that they eat or the way they exercise because healthy foods are either not affordable or available within their neighborhoods. If we'd like to create models that say if a clinical practice invests in the kind of policy changes that could occur within the neighborhoods that those patients live, so that there's greater likelihood that there'll be a farmer's market or that zoning changes will take place to create incentives for fresh produce to be sold in the neighborhood. That may ultimately be in the financial interest of the clinical practices, because if patients stay healthier, then when they get those global payments, they can keep a larger percentage for the practice. If we know what those specific metrics are that we feel like have a strong evidence base and everyone's using a similar list, I think it's much more likely we can convince insurers from one state to the next.
Okay. Thanks, Sean. I'm going to try to see if I can squeeze in some more chat box questions. That response is actually a good segue to the next question. Any tips on how to begin to understand a state health department's covered population, and that's in quotes, given historic program silos and wide variations in services provided by each program, specific eligibility requirements, and data gathered? And this might be related to the slides where, and the comments that you shared about looking at CORE and the Women's Health Network and the HIV/AIDS examples, where there was some differences in terms of what you might have expected.
Well, I think I'm glad that the caller mentions this. Because it does make it difficult when we've got in our health departments many different programs, and they have different rules, and they collect data in different ways, and then you can't look at the whole patient population. You're just looking at segments that are broken down categorically. Getting beyond that's not easy. It really takes an effort to work with our federal partners as well as with programs that are funded at the state or local level as well, and to think about whether there are ways to create some kind of uniformity. That is a planning process that might be consistent with some of the health information technology planning that is taking place in many states as states are looking at such things as meaningful usage. So I think there's not an easy answer, but it's certainly worth looking for opportunities to have some consistency in data and enrollment eligibility, and I think this is a moment when there's going to be more and more attention at trying to think creatively about how to achieve that.
Great. Operator, I'll check one last time to see if we could get a live question, and if not, we can wrap up.
We actually do have one question. It comes from the line of Fran Phillips. Please proceed with your question.
Thank you. John, thank you for a great presentation. And I was particularly struck by your story in Massachusetts about how after the legislature cut funding for immunizations, ultimately the insurance companies, I guess together with providers, agreed that it made sense to continue that in public health, and as I understood you to say, forwarded some funds to public health in order to continue to support that immunization work. And if I got that right, I just think that that's a really interesting model, and I wanted to ask you if you have ideas or perhaps examples of other kinds of public health services that might, in aggregate, be determined public good and therefore not subject to fee-for-service, but rather something that the providers or the payers could collectively support through new channels, new models, in other words.
Thank you for that feedback. Just right at the moment, I'm not thinking of other ones, but I do think that there are other opportunities. So let me mention one that does come to mind now that I think for a minute. One approach that historically has been taken by local and state health departments are to provide free flu vaccine clinics. You know, we've always done those where we go to high-risk populations among the elderly and we just line people up and give them free flu shots. In Massachusetts over the last several years, there had been an effort to ask whether it was possible for the local health departments that were providing those flu shots to actually bill for the administration of the shot, and then to use that as a source of revenue for the local health departments. It took a little bit of work to talk to each one of the insurance companies and get their buy-in, but they ultimately saw that, again, like the childhood immunizations, this one was in their interest because patients were more likely to stay healthy if they had flu vaccines. And so they agreed to allow the local health departments that qualified under some kind of minimal standards to not only do the administration but to submit a bill. We established a administrative mechanism for the health departments to submit seasonal flu vaccine bills throughout the flu season and then get paid all at once at the end. So again, it kind of was a new model, but one because the culture had been never bill. No patients in any of those instances that I hear complained about that. People were accustomed to just handing over their insurance card for a free service, and they were certainly willing to do that, and it ended up diversifying the funding base of local health.
Great. Thank you.
Well, I think we've reached the end of the webinar, John. I want to thank you again for your presentation. I also want to thank all of the participants for the great questions that were coming into the chat box. I apologize that we weren't able to get through all of them. As I mentioned at the top of the call, you'll be immediately directed following the webinar here to an evaluation. Please take a few minutes to complete the survey to help us planning with some future webinars that we're doing on community health needs assessments and accountable care organizations, just as a preview. Again, thank you to the Centers for Disease Control and Prevention for sponsoring this webinar, and for John for your really informative presentation. And I think that was reflected by the questions that were coming into the chat box and the last question that you fielded from Fran. A recording of the webinar is going to be available on our website within the next few days, and the web address is on your screen now. We hope that you'll use this as a resource and share the link with others once it's available. Thank you very much, and hope you all enjoy the rest of your day. Thank you.